Welcome back to the deep dive. Today, we are strapping in for quite a topic, the body's braking system. We're talking adrenergic blockers.
Also known as sympatholytics.
Exactly. And if you've ever felt a bit lost in that, well, alphabet soup of receptors, alpha-1, beta-2, selective, non-selective, our mission today is really to cut through all that complexity. We want to get to the core clinical impact of these drugs.
That's a great way to put it, because if our last deep dive covered the agonists, those drugs that, mimic our fight-or-flight hormones, norepinephrine and epinephrine.
Right, the gas pedal.
Then this time, it's the complete opposite. We're focused on the antagonists, or blockers. These are the drugs that actually bind to those same adrenergic receptor sites, but they inhibit the sympathetic nervous system response.
They literally put the brake on.
They do. They slow things down.
Okay, so let's maybe start with a quick receptor map then, because knowing the target location, that really determines everything, doesn't it? Where are we putting up these roadblocks?
Yeah, absolutely key. We have 3 main locations, and honestly, remembering these helps make sense of all the therapeutic uses. First, alpha-1 receptors. They're mainly on the postsynaptic effector cells.
So like the arteries, where they cause vasoconstriction?
Exactly. Arteries, but also importantly on the smooth muscles of the bladder and the prostate. Then you've got beta-1 receptors, highly concentrated in the heart.
The cardiac specialists.
You got it. And finally, beta-2 receptors. They're located mostly in the smooth muscle of the bronchioles, the airways, and also in peripheral blood vessels.
Okay.
So really, every single drug we discussed today is just working by blocking one or maybe more of these specific sites.
Got it. Okay, let's start on the periphery then, the first class. Yeah. Alpha blockers. So if alpha-1's main job is clamping down blood vessels, vasoconstriction, then blocking it, well, that should cause a pretty significant drop in peripheral resistance, shouldn't it?
It does, absolutely. Alpha blockers interrupt that SNS stimulation right at the alpha-1 receptors. And the immediate effects, vasodilation. That lowers peripheral vascular resistance, which ultimately brings down blood pressure.
Makes sense.
But the blockade also hits smooth muscle elsewhere, like in the eye, leading to meiosis. That's pupillary constriction, and as I mentioned, it reduces smooth muscle tone in the bladder and prostate.
Okay, so the vasodilation piece clearly explains why drugs like doxazosin and prazosin are used for hypertension. They dilate both arteries and veins.
Right.
But the use that always kind of strikes me as clever is their role in BPH, benign prostatic hyperplasia.
Yes. That's a really crucial clinical application. We're not just talking blood pressure here. We're taking advantage of the fact that alpha-1 receptors are right there on the smooth muscle of the bladder neck and the prostate itself.
Oh, okay.
So drugs like tamsulosin, alfazosin, silodosin, they block those specific receptors, causing that smooth muscle to just relax.
And that mechanical relaxation reduces the obstruction, improves urine flow.
Dramatically. Yeah, it makes a big difference for those patients.
Now, I know tamsulosin is mostly linked with men and BPH, but I remember reading it sometimes gets used off-label in women. Why would that happen?
Well, it comes back to that same smooth muscle relaxation. It's not common, but sometimes it's used for urinary retention in women or even to help pass kidney stones.
Kidney stones, yeah.
Because blocking those receptors can relax the ureters and the nearby smooth muscle, potentially making it easier for a stone to pass. It's a neat example of using a drug based purely on its mechanism, not just its primary indication.
Fascinating. Okay, now shifting gears a bit within alpha blockers, but this is where the stakes get really high. The injectable one, phentolamine. This isn't for chronic stuff, is it? This sounds like an emergency drug.
It absolutely is, and this is critical knowledge for anyone working with IV vasoactive meds. Phenylamine is the specific antidote for extravasation.
Okay, define extravasation for us again.
Right. So extravasation is when a really potent vasoconstrictor drug thing, dopamine, norepinephrine, even some chemotherapies, leaks out of the IV line and directly into the surrounding subcutaneous tissue.
Oh, wow.
And that drug just keeps constricting the local blood vessels super intensely. It basically starves the tissue of blood flow, leading to rapid ischemia, tissue death, necrosis.
That sounds horrific, limb-threatening even.
Potentially, yes. And phentolamine is the immediate countermeasure. You inject it subcutaneously, kind of in a circle around the leaky IV site, and it acts right there, locally, blocking those alpha-1 receptors. This forces immediate vasodilation, pushing blood back into that ischemic tissue. It's literally a race against time to prevent permanent damage.
Wow. Critical intervention. Okay, that's the acute side. Let's circle back to the oral alpha blockers, the ones used long-term. We have to talk about that really notorious side effect, the first dose phenomenon.
Huge safety point. The first dose phenomenon is basically a severe and often really sudden drop in blood pressure right after the patient takes their very first dose.
Why the first dose specifically?
Because the body hasn't had any time to adapt or compensate. You suddenly lose all that peripheral vascular resistance from the alpha blockade, and bam, the pressure can just plummet. Patients can get profoundly dizzy, lightheaded, even faint.
So it's the suddenness and the lack of compensation.
Exactly. It's a shock to the system, in a way. And that's why the nursing instruction is absolutely non-negotiable. Every single patient starting an alpha blocker needs to be explicitly warned about this orthostatic hypotension.
Meaning?
Meaning they must get up slowly from lying down, slowly from sitting up, especially when first starting the drug or if the dose gets increased later on.
Got it. Slow position changes. What else should patients be aware of, side effect-wise?
Well, dizziness, headaches, sometimes constipation are pretty common. But maybe more importantly, they need to know about interactions. Anything else that causes vasodilation is going to amplify the effect, like alcohol or erectile dysfunction drugs. Taking those with an alpha blocker can potentiate the hypotensive effect, leading to a really significant, potentially dangerous drop in blood pressure.
Okay, good to know. Right, that phentolamine scenario is definitely sobering. Let's switch gears now to the other big class, the beta blockers. These feel much more about chronic systemic management, especially hitting the heart, right?
Exactly. Beta blockers are probably, the most famous adrenergic blockers, mainly because of their heart protective roles. They work by competing directly with the body's own norepinephrine and epinephrine, and we usually classify them based on how specific they are.
Right. Break down those classifications for us again.
Sure. So you have the cardioselective agents. These are the beta-1 blockers. They primarily target the beta-1 receptors located where?
In the heart, like atenolol, metoprolol.
Perfect. Then you have the non-selective blockers. These hit both beta-1 and beta-2 receptors. So they affect the heart, but also the lungs and peripheral vessels. Propranolol, sodilol are the classic examples there. And then there are even some hybrids like carvedilol and labetalol. They actually have both beta and alpha blocking activity, so they give you wider effects, hitting both heart rate and vascular tone.
Interesting. Okay, let's focus first on the main target, beta-1 blockade in the heart. What are the clinical wins we get by putting the brake specifically on the heart muscle stimulation?
Oh, the benefits are huge and really threefold. Blocking beta-1 receptors leads to a decreased heart rate, it slows down the electrical conduction through the AV node, and importantly, it decreases the force of contraction.
Less forceful squeeze.
Right, and that reduction in how hard the heart has to work is key. It lowers the heart's demand for oxygen.
And that's why they're considered cardioprotective after a heart attack, an MI. You're basically telling the damaged heart muscle, hey, take it easy, don't work so hard while you heal.
Precisely. You're protecting it from being overworked by all those stress hormones, the catecholamines that surge during and after an MI. It creates a lower oxygen demand environment for healing. And that same mechanism, reducing oxygen demand, makes them great for managing angina too.
Makes sense. Now let's talk about the flip side, the critical safety issue, the non-selective beta-2 blockade. This is where patient assessment becomes potentially life or death, especially thinking about the lungs.
You absolutely have to remember where those beta-2 receptors are heavily concentrated in the smooth muscle of the bronchioles, the airways.
Okay.
So if you block those beta-2 receptors with a non-selective drug, what happens? That smooth muscle contracts, it tightens, leading to bronchospasm and airway narrowing.
Which is terrible news for someone with asthma or COPD.
Exactly. That's why non-selective beta blockers are generally a big no-no, contraindicated, in anyone with reactive airway disease. You are essentially risking closing off their airways.
Okay, very clear risk. Now, something else fascinating and potentially dangerous is the metabolic impact, right? Especially with non-selective ones interfering with blood sugar response.
They absolutely do. It's twofold, really. First, non-selective agents block glycogenolysis. That's the liver's process of breaking down stored glycogen into glucose to raise blood sugar.
So if someone's blood sugar drops,
they might recover much more slowly because the blocker is hindering that natural response. But even more critically, especially for diabetic patients, these drugs can mask the typical warning signs of hypoglycemia, of low blood sugar.
How so? What signs get masked?
Well, think about the usual signs. tachycardia, that racing heart feeling, tremors, nervousness, those are largely driven by the sympathetic nervous system kicking in.
Which the beta blocker is blocking.
Right, so the patient might be crashing, blood sugar plummeting, but they don't get those usual alarms. Their heart rate stays steady, they don't feel shaky.
That's incredibly dangerous. Is there any sign that usually remains? What do we teach patients to look out for?
The one key sign that often persists despite the blockade is sweating, diaphoresis. That becomes the most reliable indicator they might be hypoglycemic. That's a crucial teaching point.
Sweating, got it.
And just to add another layer of complexity, they can sometimes cause hyperglycemia too, messing with insulin sensitivity. So bottom line, careful blood glucose monitoring is absolutely essential for diabetic patients on non-selective beta blockers.
Okay, so beyond the heart and lungs, let's just quickly revisit propranolol. You mentioned it's non-selective, but it has another property, high lipophilicity.
Yes, it's very fat soluble. And what that means pharmacologically is that it can easily cross the blood-brain barrier and get into the central nervous system.
Into the brain.
Right. And that CNS access is why propranolol has some unique uses outside of cardiology. It's often effective for managing essential tremors, and it's also used prophylactically to prevent migraine headaches.
Interesting how that one property opens up different uses.
Yeah.
Okay, we absolutely have to address the single most critical safety alert for this entire class of drugs, abrupt withdrawal. This is non-negotiable knowledge.
You cannot emphasize this enough. It carries a black box warning from the FDA, and every patient needs to understand this. Beta blocker therapy must never be stopped suddenly. Cold turkey is dangerous.
Why? What happens?
It needs to be tapered off slowly, usually over 1 to 2 weeks. If you stop abruptly, you risk severe rebound hypertension, where the blood pressure shoots way up. You can precipitate a heart attack, an MI, or cause a sudden severe worsening of angina.
Okay. Capering is essential. Now, before we jump into the nursing process, there's that high alert medication error issue with metoprolol that apparently trips up even seasoned clinicians. Can you clarify that?
Yes, this is a really common source of errors, unfortunately. It boils down to 2 different salt forms of metoprolol. You have metoprolol succinate. That's the extended release, or ER form. It's usually dosed just once a day. Then you have metoprolol tartrate. That's the immediate release form, usually dosed twice a day.
Succinate is long-acting, once daily. Tartrate is short-acting, twice daily. What's the error?
The error is confusing them. If a patient is stable on the once daily succinate and someone mistakenly gives them the twice daily tartrate but only once a day, well, they're only getting half the coverage they need. Their BP or heart rate control could fail later in the day.
Right.
Conversely, if someone is supposed to get the twice daily tartrate, but they're mistakenly given the once daily long-acting succinate twice a day, now they could get severely bradycardic or hypotensive because they have way too much drug effect overlapping.
Wow. Okay, so it's not just the name, it's the release mechanism and the dosing frequency tied to it.
Exactly. It just highlights how crucial it is to read the full drug name, including the salt form, and verify the intended dosing frequency with the prescription. Needs absolute clarity.
Absolutely essential. Okay, section 3. Bringing it all together in clinical practice. How do we translate all this pharmacology into safe, effective patient care? Where does the nursing assessment start?
Well, given the risks we just discussed, it has to start with a respiratory history, especially if a non-selective agent is being considered. We must confirm, absolutely confirm, there's no history of asthma, COPD, or similar conditions.
Makes sense.
But really, for any beta blocker, even the cardioselective ones, we need a solid baseline cardiac assessment. Does the patient already have bradycardia, significant heart failure, any kind of heart block? These are red flags because the drug will likely worsen those conditions by slowing conduction and contractility even further.
Okay, baseline assessment is critical. Then during implementation, actually giving the drug, we have those vital sign parameters. Counting the apical pulse for a full minute, measuring BP both lying down and standing up. Why the specific cutoffs? Why call the prescriber immediately if the heart rate is under 60 or the systolic BP is under, say, 100?
Yeah, those aren't arbitrary numbers. They represent a sort of clinical safety margin. If an adult's heart rate drops below 60, we start worrying about adequate cardiac output. Is the heart pumping enough blood to perfuse the vital organs, especially the brain?
Okay.
And if the systolic pressure is already low, maybe 90 or 95 before the dose, giving another drug that lowers BP further pushes them into clear hypotension. That increases the risk of dizziness. Falls, yes, But critically, it can also compromise blood flow to the heart muscle itself, inadequate coronary perfusion.
So we're protecting the brain and the heart by holding the dose at those thresholds.
Precisely. It gives the prescriber a chance to reassess if the dose is too high or something else is going on.
Got it. That clarifies the rationale nicely. We also touched on some key patient teaching points, particularly around lifestyle adjustments.
Yes, absolutely. Since orthostatic hypotension, that dizziness on standing up is an ongoing risk with both alpha and beta blockers. Patients need to be super careful about anything that causes additional, unnecessary vasodilation.
Things that make blood vessels relax even more.
Exactly. So limiting alcohol intake is important, avoiding really excessive exercise, especially in the heat, and being very cautious with exposure to hot environments. Think saunas, hot tubs, even just really long, hot showers or baths.
Why hot showers?
Because the heat causes peripheral vasodilation. If your vessels are already relaxed from the medication, adding heat on top of that can dramatically drop your blood pressure and increase the risk of fainting.
Okay, that makes sense. And what about monitoring for fluid balance? You mentioned weight checks.
Yes, crucial, especially for patients taking these drugs for heart failure, but good practice for many. Counsel them to weigh themselves daily. Same time, at same scale, similar clothing. And they must report immediately if they gain 2 pounds or more in a single day or 5 pounds or more in a week.
What does that sudden weight gain signify?
It's often the earliest sign of fluid retention, edema, suggesting their heart failure might be worsening, and that requires prompt medical attention.
Got it. Daily weights report significant gains. Okay, let's tie some of this together with that clinical example you mentioned earlier, the one that really highlights the non-selective risk. The patient with asthma who got propranolol after their MI.
Right. This was a textbook, unfortunately, real-world example of why selectivity matters. So this patient had stable, pretty mild asthma, well controlled. After a heart attack, they were quite appropriately prescribed a beta blocker for cardioprotection. The problem: they were given propranolol, a non-selective agent.
Right.
Within just a few days, the patient started reporting worsening shortness of breath. They felt tight-chested, wheezy.
So the drug was working on the heart.
Exactly. The beta-1 blockade was doing its job, helping the heart. But the simultaneous beta-2 blockade was hitting the lungs, causing significant bronchoconstriction. It was essentially triggering an asthma exacerbation.
Wow. And the fix?
Simple, but critical. Switch the medication. They were changed to a cardioselective beta-1 blocker like metoprolol. That way, they still got the essential cardiac benefits, but without negatively impacting their airways.
That case just perfectly underscores why knowing the receptor selectivity and getting a thorough patient history is so incredibly important. Okay, let's try and boil this down. What are the absolute core takeaways?
I'd say the core difference lies in their main targets and effects. Alpha blockers, think pressure and plumbing. Primarily managing hypertension and urinary obstruction, like in BPH, plus that special rescue role for extravasation.
Okay.
Beta blockers, think the cardiac engine, primarily managing the heart post-MI protection, slowing down dysrhythmias, helping with hypertension and heart failure.
And the key risks?
For alpha blockers, it's that first dose phenomenon, the orthostatic hypotension. For beta blockers, especially the non-selective ones, it's a dual danger: bronchoconstriction in susceptible patients and the masking of hypoglycemia symptoms, particularly in diabetics. And for all beta blockers, that critical warning about never stopping them abruptly.
Right. We've definitely established these drugs fundamentally change the body's stress response. And we hit that black box warning hard to the need for a slow withdrawal. But let's dig just one level deeper for our final thought. What is the precise underlying physiological danger? What's happening at the receptor level that makes stopping beta blockers suddenly so potentially life-threatening?
That's a great question to end on. It's all about receptor sensitivity and numbers. See, while the receptors are being consistently blocked by the drug, the cells kind of notice the lack of stimulation, and they respond over time by increasing the number of receptors on their surface. They become more sensitive, trying to catch any little signal they can. This is called upregulation.
Okay, more receptors, super sensitive receptors.
Exactly. Then if you suddenly remove the blocking drug, the body's natural catecholamines, norepinephrine, epinephrine, which are always circulating at some level, suddenly have access to this vastly increased number of hypersensitive receptors. And the result is a massive, overwhelming, unchecked surge of sympathetic activity. Everything the drug was suppressing comes roaring back, but amplified. That's the rebound hypertension, the potential MI, the worsening angina. The system is dangerously over-responsive.
Wow. That paints a really clear picture of the danger. It's a powerful reminder. These aren't just minor tweaks. They're significant physiological interventions. Requires meticulous patient education, careful monitoring, and strict adherence to prevent those severe rebound effects. Thank you so much for guiding us through this complex but crucial deep dive into adrenergic blockers today.
My pleasure. It's vital material.
Absolutely. To everyone listening, definitely review your notes on receptor specificity, alpha versus beta, 1 versus 2. It really is the foundation for understanding these drugs. We'll catch you next time on The Deep Dive.